Good afternoon, everyone, and welcome to the SAMHSA-HRSA Center for Integrated Health Solutions, also known as CIHS webcast, titled Before You Say Ah, Integrating Oral Health and Behavioral Health in Primary Care Settings. My name is Laura Michael, CIHS Associate, and your moderator for today's webinar. As you may know, the SAMHSA-HRSA CIHS promotes the development of integrated primary and behavioral health, including mental health and substance use services to better address the needs of individuals with mental health and substance use conditions, whether seen in specialty behavioral health or primary care provider settings. In addition to national webinars designed to help providers integrate care, the Center is continually posting practical tools and resources to the CIHS website, providing direct phone consultation to providers and stakeholder groups, and directly working with SAMHSA primary and behavioral health care integration grantees and HRSA-funded health centers. Before we get started, a couple of housekeeping items. To download the presentation slides, please click the drop-down menu labeled Event Resources on the bottom left of your screen. The slides are also available on the CIHS National Council website, located under the tab About Us/Webinars. During today's presentation, your slides will be automatically synchronized with the audio, so you will not need to flip any slides to follow along. You will listen to audio through your computer speakers, so please ensure they are on and the volume is up. You may submit questions to the speakers at any time during the presentation by typing a question into the Ask a Question box in the lower left portion of your player. Finally, if you need technical assistance, please click on the question mark button in the upper right corner of your player to see a list of frequently asked questions and contact info for tech support if needed. Now, I'll turn it over to Nick to introduce today's speakers and discuss our objectives. Nick?
Thanks, Laura. And so for today, our learning objectives are going to be to engage patients in effective conversations about their oral health, identify when a patient may have an oral health concern, and a list of resources and strategies for effectively addressing oral health issues. And so we'd like to thank you for joining us today, and today's webinar is a little bit different. We're hoping that it's more of a casual conversation about oral health and really some information to help us in integration really get comfortable in talking about oral health issues. Many of us are concerned about these issues but could really use some extra support and some tips and tricks and ways to more effectively communicate with our colleagues and our patients around these issues. So today I'd like to introduce our speakers. Dr. Renee Joskow, the Senior Dental Advisor for Health Resources and Services Administration, and Anita Glicken, Program Consultant and Project Leader, National Interprofessional Initiative on Oral Health, Associate Dean, and Professor Emerita, University of Colorado School of Medicine. So with that, Dr. Joskow, I'd like to hand it over to you.
Thank you, Nick. Good afternoon, everybody. Welcome. Professor Glicken and I were asked to have a dialogue about the intersection of our two professions and our areas of expertise. So we'd like to, as Nick was mentioning, approach today with a little new format or something different. So we're planning on today's webinar being more of an engagement webinar in order to increase awareness of oral health. So Nick presented to you what the objectives are. But one of the things that we wanted to share with you, too, is a little bit different perspective or a different way to think about it. Why should behavioral health providers be involved in oral health? How can the behavioral health community recognize when one of your clients has an oral health issue? We hope to provide, and we will be providing and discussing some tools and some pieces of information and tips to help you engage and empower your patients in promoting oral health, as well as your own, of course. And, of course, we want to also talk about how behavioral health providers can get involved and learn more about oral health. Now, Professor Glicken and I have been working together for many years now on integrating oral health in primary care. And I was hoping that she might be willing to share with you all, as a fellow behavioral health provider, how she became interested in oral health perspective. Anita or Dr. Glicken, are you willing to talk about this today?
I'd love to talk about it. Thank you very much, Dr. Joskow, and hello, everyone. I think I'd like to answer your question with a story. In February of 2007, when newspapers across the country carried the story of the death of 12-year-old Diamante Driver, who died in the shadow of our nation's capital from an apparent toothache, while his mother sought care for his younger brother, who himself had severe dental decay. If you were a physician assistant, a nurse practitioner, a doctor, or a behavioral health care provider, I think you might have read this story, shook your head, and said how unfortunate that this family couldn't find a dentist. It's too bad we couldn't do something about this. Well, 9 years later, those same providers are learning that by redefining the problem and viewing it through a lens of this integrated healthcare delivery system, they are very much an important part of the oral health solution. So providers are also learning at this point that in order to address problems like Diamante's, to reduce oral health disparities, to eradicate dental disease, to integrate care needs, we need to include all members of the healthcare team. And on this webinar today, I'm delighted that we're really noting the added value of behavioral health providers, because this story is really what compelled myself as a behavioral health provider and others, I think, to pay attention to oral health and to begin to consider how we might move change to integrate oral health into education and practice so that we could more effectively work together as a team to address an issue that for many of us we've overlooked and undervalued for a very long time. I think we'd like to start this morning by taking a poll of the audience, and I'm going to suggest that we do that now, because that poll will really help us to get some broad idea of how much attention behavioral health providers are currently paying to oral health. So can we launch that poll question?
Yes.
And will we see that, the answer to that coming up on our screen?
So we're just giving them about a few more seconds to finish up, and the results will be sent to the audience.
Great, thank you.
Yeah, we recognize that today is really about starting a discussion, starting the dialogue, and that we likely have a broad range of people participating in today's call. So we really did want to get a read on what your experience has been with oral health, but it also provides us opportunities for future engagement with you all, since you represent the full spectrum of behavioral health integration providers and practitioners.
So the audience should be able to see the results now. I can actually read it out in case you can't see that, Dr. Glicken.
No, I can't. Be helpful.
Yeah.
Okay, so I can go ahead and read that. So for yes with most patients, that is 41.34%. For yes with some clients, that is 20.08%. Yes, but rarely, that is 16.5%. And then no, I typically have no addressed client oral health in my work with clients, and that's 22%.
Thank you. I think that really speaks to the broad participation that we're already beginning to see across the behavioral health provider spectrum, and also, though, the opportunities we have to continue to look for other ways to integrate oral health and to champion oral health across our systems. Dr. Joskow, when I talk with other health professionals who work outside of what we've traditionally called the dentist domain, the first question they often ask me is, why now? I wonder if you can help us understand how we got here and why this has become a critical issue at this time.
Sure. I don't know that it's really a new issue. As a matter of fact, I would say it's certainly not a new issue. There were even Institute of Medicine reports dating back to the 1970s that were specifically addressing interprofessional care, team-based care, and the need for integration in primary care. But right now, it's been gaining a lot of attention, and there is a sense of urgency, partially, I think, as a result of what happened to Diamante Driver that you just described. Another piece of this, though, is that I think we are all recognizing that the primary care delivery system is shifting. So if I were to think about this, I think I can easily come up with maybe 4 different drivers. So let me just pose those or postulate those. So now there is an emphasis on patient-centered care. There's the Centers for Medicaid, Medicare Services, CMS, meaningful use, and other incentives to have certification as a patient-centered medical home. I like the term patient-centered health or even wellness home because that is, in my mind, incorporates as well as medicine, both behavioral health and oral health. But most patients, we recognize that most patients in the primary care settings would benefit from some oral health interventions. Let me share with you some information, at least from HRSA's program perspective. In 2012 alone, half or 50% of all primary care visits involved underlying behavioral health disorders. In that same year, HRSA's Health Center program provided over 5 million mental health visits, 1 million substance abuse services, and more than 1.4 a little bit more than 1.4 million patients with mood disorders. Now, all of these are areas that you're addressing in the behavioral health domain, but these are areas that can dramatically impact their oral health as well, which is things like substance abuse or behavioral health disorders. So that's one area, the emphasis on the patient-centered home. The second one is the idea of us shifting the management of care to the primary care setting. So things like having a PCM or primary care manager, even though we have in the United States a highly tertiary care-focused delivery model, they're now both through payers driving it in cost containment and pay for performance. There's an emphasis now on the management and overall case management of a person's care, and that being directed towards the primary care setting. So that would be the second thing I could think of. Additionally, something that's been gaining traction over more than a decade is increasing evidence of an oral systemic connection of health conditions and disease manifestations, and really the bidirectionality of that there are oral conditions that affect systemic health or medication use that affects oral health, and certain diseases even can be detected in the mouth first before other parts of the body. So that would be maybe the third thing. And then finally, I would say that there's been great strides and huge advances and efforts and really good models to integrate all aspects of care into the primary care setting. Now, if we talk about the proportion of patients who receive dental care versus medical care, I think that highlights an opportunity. And I want to take a step back for a moment and talk about how we got there and why we have this national movement to integrate oral health and primary care. So in the U.S. and other countries, patient care typically has been fragmented in terms of medicine and dentistry. Many of our populations see a physician regularly. However, they don't visit a dentist. This is particularly pronounced for young children as it relates to well-child visits and immunizations and other preventive services. And in fact, in 2011, as the slide demonstrates, according to the MEPS or Medical Expenditure Panel, 111 million persons across all ages had actually visited a physician but not seen a dentist. And that contrasts dramatically to the only 27 million who saw a dentist with no physician. So this discrepancy is due to a variety of reasons, which we'll touch upon a little later, but they do include access issues, payment issues, attitudes, beliefs, etc. Now, this slide also, if we think of this conceptually, it really illustrates millions and millions of missed opportunities for primary healthcare provider teams and all the individuals as part of that team to engage patients in preventive oral care and screening for early diagnosis or early detection or identification of disease and referral to the appropriate person, perhaps a dentist, for any significant oral health problems. That's also true for the 27 million who see a dentist. It's an opportunity for them to be referred into the medical or behavioral health system as well and get them connected there. So we can also talk about, or I just want to touch upon the fact that fewer state Medicaid programs participate or support preventive care services for early diagnosis. And in particular, we have to acknowledge that what is covered by Medicaid is a state decision, and oral health or dental services are covered to some extent by most states, but they're often limited for adults. And again, so we're looking at opportunities for integration and ways to reach populations who might lack access to dental care, but the way that we would like to approach this or have discussion about today is how do we maximize those partnerships and referral agreements with behavioral health providers and primary care providers and the dental community. So I'd like to just take a moment and just very briefly share with you some resources and just make you aware that we started this whole, I think, this movement to maximize momentum. And in looking at the slide here, I see that we have a graphics issue. I think this occurred when we uploaded the slide into this platform, but our administrative colleagues and have assured me that we'll be able to email this corrected slide out to you, and that the slide deck, when you download it, will have the correct visual on here. So I apologize for the difficulty reading the background. But the Surgeon General's report was released in 2000, and that talks about that oral systemic connection. It talks about access to care. That was followed immediately by a national call to action by Surgeon General Carmona. And then if we want to just jump up into the next decade already, the yellow document in 2011 is the Interprofessional Education Competencies, and that's really one of the significant drivers in curriculum. And many of you, there's 41% who say you address oral health with most patients. Perhaps that was included in some of your training and education and part of the curriculum changes. And then HRSA commissioned the IOM for the two 2011 reports, Advancing Oral Health in America and Improving Access to Oral Health Care for Vulnerable and Underserved Populations. And I hope you'll look to these documents as resources and references. These two documents were particularly important to us because they've included so many recommendations, 17 recommendations in total for both HRSA and for HHS to help address this huge disparity and gap in accessing care, specifically in oral health. And then if we look just most recently, just to make you aware, we just released earlier this year in the Public Health Reports is the new HHS, Health and Human Services Oral Health Strategic Framework, which includes input in an oral health plan from SAMHSA. So these are some resources and some tools that I did want to make you aware of. It is important as well that in the Public Health Reports and in that HHS framework, as well as all these documents, we talk about the use and the expansion right now of federally qualified health centers, or HRSA's health center program, because this is an area where integration of both behavioral health and oral health has just skyrocketed. And we've actually had pilot projects at health centers looking at this integration, and in your resources at the end of today's presentation, there's even another webinar specifically providing one example of a health center that has integrated both behavioral health and oral health. So I think you'll find that interesting as well. I'm wondering, Professor Glicken, if you want to talk a little bit more, or if you can tie this in the use of FQHCs or even any of these Sentinel documents into how they would relate to behavioral health or behavioral health providers.
Well, I think one of the things I just want to call out again is the document in 2011 from the Interprofessional Education Collaborative, who, with HRSA support, created the set of competencies that really helps us support these new models of care, and as you say, are now increasingly integrated into health professions education. But I think what I want to really note is, in particular, that collaborative added new partners, and they specifically added psychology, social work, and allied health, which I think helps again to recognize that added value of the behavioral health workforce on the primary care team. Oral health not only fits into the scope of practice for behavioral health providers, but it also provides a great exemplar of a place in our interprofessional education and practice models where working together truly helps us make a difference in the lives of our clients. So I just wanted to make an effort to call that out in particular.
So let me just interject and ask you, so it sounds like with these kind of more complex and more diverse teams, is there a better understanding or is there a sensitivity or awareness of the oral systemic connection, or it's just from the provider type perspective?
Well, I think one of the ways for us to think about this is to consider how long we often ignored as professions the impact of the mind and behavior on the body. Many of us in behavioral health are familiar that we operated in a fragmented education and delivery system that really often divorced the mind from the body. And I think we find ourselves in a similar situation today with oral health, where we separated the mouth from the body, and we built that into the cultures of medicine and dentistry, and resulting again in similar siloed training programs, professional identities, payment and delivery systems that largely did divorce dentistry from traditional primary medical care. You mentioned earlier, Dr. Joskow, but I also see from the behavioral health perspective that our primary care medical system is in the midst of transforming, and we're transforming to a more patient-centered and coordinated, value-oriented system of care. And in part, the slide that you see in front of you also shows that this is in part due to the fact that increasingly we see published science that suggests that there is this oral systemic link, and that before clinicians ask their clients to say, we need to really think more broadly about these issues. And that certainly brings with it new expectations. It certainly brings new challenges for care. But we recognize that it also brings a number of new opportunities for us to reach across our siloed system and really engage behavioral health so that we can put both the mind and the body back in both the mind and the mouth back in the body. I think as we increasingly integrate behavioral health, it's important that as providers, we come to primary care not only equipped with this mind-body integration, but also the understanding that the mouth really is the gateway to the body and can't be ignored, and that a healthy mouth is essential for overall health. And I'm particularly pleased that so many of the people on the call today have actually been thinking about those things as they conduct interviews and screen patients.
Do you think this might be a good time for us to maybe share, I know I have some, but perhaps you have some examples that you would like to share with the audience as well? I'll let you go first if you like.
I'd actually love to share some examples. I have a recent example in that I was speaking with the Chief Executive Officer of the National Association of Social Workers, and he shared that he had been talking with students about the importance of oral health since we'd had a conversation. And at one of these visits, he was approached by a student who shared the story that he was completing a clinical rotation in a geriatric center when he was approached by a physician on the staff. And the physician reported that the patient needed a referral for psych, wanted the social work student to do that, and he wanted the patient referred to psych because of depression. The student said that he'd be happy to do that after he spoke with the patient about this, And the physician jumped in and told the student that there really wasn't a need for that the patient had stopped eating. So clearly she was very depressed and needed a psych referral. Well, the student went ahead and visited the patient, in part to introduce this notion of a referral, but noted that when he walked in, the patient appeared to be in pain and was holding the side of her face. It turned out that that patient had severe periodontal disease. She was unable to eat due to the pain she experienced each time she tried to do so. So the student quickly shared that information with the team, who immediately initiated a dental referral and also provided then the psychosocial support that the patient needed related to the pain and the dental experience she was having.
Wow, that's powerful, and I think it's so striking and so poignant of how sometimes assumptions are made, and actions are taken before really everything's explored. It kind of reminds me as well of this issue that comes up very often in dentistry, or you hear, I don't know if you hear it in your area, but there's a lot of commercials for sedation dentistry and are you afraid of going to the dentist? And perhaps there are some people on the call who feel that way. And there are plenty of patients who are dental phobic and they may be referred to a dentist. And we are taught in dental school how to address the psychosocial basis of medical practice, how to talk to patients, and we're taught some tools and skills. But we can best address the needs for those who have expressed their concerns and fears, and some may, in fact, seek sedation dentistry. But very often, or more often, people won't talk about their concerns, at least in my experience, not to the dentist. So I can imagine that the behavioral health provider or you, Professor Glicken, or your colleagues could be working with a patient to actually, you might already be seeing them to help them address their fears in general or even specifically. But I think you can also be of assistance to the dental providers to help us address the needs of the dental patient. And specifically what I'm thinking of is a patient of mine who was referred to me who had seen multiple dentists, and no one was able to even perform an examination. And these are the cases that, even in dental school, they warn us, don't think you're going to be the first person to be able to treat this person when everybody else has failed, shall we say. But they weren't even nobody was able to even take diagnostic x-rays or even use a mirror in her mouth. So she was referred to me, and using motivational interviewing, desensitization, we actually learned, and talking to the patient, rather than trying to address this from a dental or procedure or treatment perspective, I think we used more of the techniques that your profession used, and we were actually able to learn of the underlying cause of this exaggerated gag reflex that she had, which really precluded her from having having her dental care provided. And it turns out that she had a tonsillectomy as a child without any anesthesia. Now, when I had heard this from the patient, I obviously had a different understanding of what was behind this physiologic response. So ultimately, the good news is we were ultimately able to work with her in using techniques, and we were able to provide all of her necessary restorative care and preventive treatment in an outpatient setting with local anesthetic. So it also, though, brings up the point that I could see now, years later, that this would have been a great opportunity for me to engage behavioral health professionals to help me or help others like me that might be seeing patients with similar issues, really help those patients get the care that they need.
That's a great example, and it actually brings to mind for me another situation that was related to me by a physician assistant colleague who told me about a case he was involved in as part of a medical team a few years back that was caring for a pregnant patient. And the medical team, as he described it, and he describes this in a video that's actually called Joining the Fight for Oral Health, that's on the opening page of the Smiles for Life curriculum, the free online curriculum that we have a resource slide for at the end of our presentation, he tells this story about being part of this team where they were caring for a pregnant patient, and they had diligently all been tracking her health and the baby's progress throughout her pregnancy. Unfortunately, he shares that this mother lost her baby late in the pregnancy, and he later learned that she'd had overwhelming sepsis from an infection in her mouth and had previously been told by her family that she shouldn't volunteer this information because she shouldn't receive dental care during pregnancy. He reflected with me about how tragic that was, that if any of the healthcare team had thought to pay attention to her mouth and focused on her mouth as part of her body, that whole situation may have been avoided and her baby may be alive today. By all of the providers who were there focusing on the baby but ignoring the dental problem, they ignored the potential risks to the pregnancy. And I think having a behavioral health provider on board, someone who we often bring to the table really the unique lens of looking at the whole person and whole person care, that situation could have turned out very differently.
Yeah, that's a really important point. And I think, too, that also reminds me of the role of family and how important, you're talking about pregnancy and then that child that's born there, but it also reminds me of the role of the behavioral health provider. It reminds me of something that I just recently heard where one of my colleagues, a primary care provider, referred the child in their facility to the dentist, but the family never made the appointment. And it was interesting that it actually was the behavioral health provider who saw the flag in the electronic health record that the child never came in for that dental appointment. And they have an integrated health team perspective. And so the case manager, who was the behavioral health provider, had taken upon themselves their role as the case manager to follow up on why they didn't keep the appointment. And so they reached out to the family and learned that the family was concerned that the child might be taken away from them because that had happened to another family they knew. So they didn't seek care out of fear from social services or other things, that actually just a story that they had heard from someone else. So again, I think this is another example where the behavioral health provider played a critical role in managing and facilitating the health of both the family and thus the community in this case, because their intervention, I think, also eventually impacted the other family that they knew about.
I think that's really true, and these are just obviously a few of the examples that we both could pull from our experience, and I'm sure that others on the call could add to. But it really speaks to the need for the whole team to respond appropriately to these patient-specific needs and concerns. I think integrating care really not only allows behavioral health providers to identify health issues that may impact a patient's oral health along with the rest of the team members, but it also enables other members of the healthcare team to engage us as behavioral health providers when oral health issues suggest that there may be a behavioral mental health concern or that social support is indicated. Why don't we transition? This might be a good time to transition to how we talk about screening for oral health issues in the care that we deliver. Can you tell us a little bit about how this is the same or different from the process that we as behavioral health providers might use to identify other problems?
Sure. I think, I believe that the SOAP model that is used in medicine and dentistry is also used certainly across many aspects of behavioral health. So, I think we can address that now. I think the opportunity is also there to utilize, at least on our slide we're depicting here on the right-hand side, is an example of a medical history form, just like you might have a psychological history profile, a dental history. I think the behavioral health provider, as they approach their clients, they have an opportunity, too, to look at whatever history forms or information from a history that they are eliciting from their clients. So in doing that, they can also be screening for oral health issues. So things like even weight loss might be an indication, as the example you gave earlier, or somebody that doesn't want to eat might be an indication of a dental problem. I don't think these issues are different, but it gives us an opportunity to identify other problems. So now we're just looking at using the SOAP perspective or a health history, a health questionnaire, with an oral health lens. And these can be used to identify when a client has an oral health concern. It can be used, the SOAP perspective, as documentation and referral as well. And so obviously everybody starts with a chief complaint or what that person comes in with, but the behavioral health provider, as part of the primary care team, has the opportunity to pick up on these things that may be prior to or earlier in the process from when they might see a dentist or even see a medical care provider. The objective component, for example, that the behavioral health provider can use is that you might include observations of how that individual, how your client is speaking, the manner that they're speaking, physically how they're speaking, whether they cover their mouth or any behaviors associated with their mouth or oral cavity. Are they having problems swallowing? Does it seem that they have maybe dry mouth or something's funny going on? That just might be a cue to you that other health providers may not pick up on. And all of those might be an indication of an underlying problem, either systemic, that has oral manifestations. So I think even in your interaction with your clients, there's an opportunity there. The assessment component will obviously be within the scope of your particular practice, and the plan perspective, or the P, would be what your next steps would be, whether that would include referral or education or things of that nature. So in terms of oral health, maybe we should consider how identifying oral health problems is similar or different from what the other behavioral health providers are already doing. I know that some use the SOAP, but Anita, are there, from your perspective or your experience, are there other ways to look at this problem as a behavioral health provider?
I'd like to take a minute to maybe mention this oral health delivery framework issued recently in a white paper from Qualis Health. This framework, which my observation is increasingly being used nationally to educate providers about ways to approach oral health care in the delivery setting, is very similar and parallels the SOAP note in so many respects, because what you see here is that the first phase is to ask a question, and this is really asking about symptoms that might suggest oral disease and factors that place clients at an increased risk, similar to your subjective observations. We have look, which is more objective. We're looking for signs that indicate oral health risk or active oral disease. And then we make a decision. We're thinking about and we're deciding what the appropriate response might be, part of our assessment. And then we decide to act. Now, for behavioral health providers, that could be directly delivering preventive interventions. It might be involving therapy for tobacco, alcohol, or drug addiction. It might be referral. But we would act on those. And then from there, probably most importantly, we also be sure that we're documenting and providing data to other health professionals about what we've done and giving us some potential outcomes that we can monitor as we go forward. As I think about this, though, we've talked a lot about how do we collect this information. It's really important that we not only identify a concern, but as all providers, we have to engage in meaningful and effective conversations with our clients about their oral health. Can you give us some thoughts about how we might do that?
Sure. I think there are some concrete examples of what a behavioral health provider can do. So, as we talked about before, the importance of engaging clients in effective conversation, but to also include oral health. So one of the things that you could be thinking about is identifying patient-specific barriers or challenges. I think your profession, more than anyone, are experts often in motivational interviewing, and you can work with the patient to find out what is likely to help them change behavior. You're so often working in the area of empowerment and behavioral change. And as I mentioned earlier, this is an opportunity that you can not only be helping your clients, but you can also be helping other healthcare providers in engaging the patient. So specifically, you can be working with dentists as well. Some of the areas specifically that are important is we know from research that many people delay or avoid treatment, dental treatment, due to fear, due to cost, due to pain. Poor health literacy overall is really a critical piece to this, but in particular we see that poor oral health literacy is even more pronounced. It's really important, too, to be tuned into the cultural beliefs and practices. We know that cultural factors have important implications for not only an individual's health, but also for those who they care for, such as children and the elderly. From some anthropology studies, as well as some cultural competency work, for some groups, the mouth is considered a sacred space. It's not okay to speak about oral issues or to speak about the mouth. There's even some groups where the mouth is seen as a window to the physical mind, body, or soul. And if we even looking, as an example, you talked about a mind-body connection, but if we think about even traditional Chinese medicine where they use tongue diagnosis, they're actually using the oral cavity as that true window to assess what else is going on in the body. There are some cultures that use liquid mercury as curatives. So we have, all these different cultural factors, but perhaps one of the things that's most pronounced with respect to oral health is the belief by some that tooth loss is inevitable and that this is related to societal and cultural norms and their own personal frame of reference from upbringing and family. So these are things that all could be gleaned from your interactions with clients. We do know that some people don't even know that oral health is connected to or impacts overall health. And I think that really speaks to an astonishing fact, which is that in 2012 alone, that emergency department emergency department visits due to dental complaint cost the U.S. healthcare system $1.6 billion. And associated with that as well is the potential to drive narcotic use and substance abuse for those that don't seek definitive care. Our emergency departments are not well suited and situated to provide definitive dental care, so often people will just get an antibiotic if it's an infection and a prescription for a pain medication. But some of the emergency departments have actually taken the next step and have created relationships with the community, both in providers, and they're recognizing this issue and the need for getting people into health homes, dental homes, and they've created relationships with community providers and federally qualified health centers. And what we have here on this slide is just to let you know that there are some resources, there is some research that's already been looking at the relationship of those with mental health conditions and dental problems and emergency department use. And on the right-hand side in particular, I want to share with you a tool which is the Association of State and Territorial Dental Directors, have numerous pieces on emergency department, what we'll call deferral, or basically we're trying to get people out of emergency departments into primary care settings. And there are some really good best practices and promising practices where the emergency department themselves has contracted with FQHCs to get people directly into care right away. And I think these are issues that, again, once we start shifting the management of the person's care and connecting that to what their needs are, I think, again, this is an opportunity for the behavioral health provider community, because you're working in primary care settings, to get engaged and to really help the patients achieve overall health, which includes oral health.
Mm-hmm. Right. Right.
So is there ways that you think, I mean, based upon what you know, what your experience has been of behavioral health in primary care communities, what the behavioral health care provider can do? Like, what might you see from your mental or behavioral health lens?
Well, I think this slide that I just put up really helps me remember that the missing piece so often prior to our ability to integrate care was the behavioral health connection, and that integrating care allows us to do that. And I think one of the unique things about behavioral health providers, often they really extend beyond a primary care health setting into the community. So they're sort of the interstitial fluid, if you will, that can connect the community to the primary care center. But I think the other thing I like to remember is that behavioral health providers might be the first member of a healthcare team to identify issues that impact client oral health. A lot of problems, whether they be mild to moderate behavioral health problems, often commonly first present in primary care settings. So if there's a behavioral health provider on board, then they frequently see issues like anxiety, depression, substance abuse in adults. We also see anxiety, behavioral problems, ADHD in children. All of these things can impact a client's oral health. For example, the medications that we know we use to treat depression can cause xerostomia or dry mouth, which can impact the enamel of the teeth. So identifying those things early, even from the behavioral health side, is very helpful. Similarly, we see that people with common chronic medical disorders, like diabetes or cardiovascular disease, maybe asthma or dementia, certainly clients with developmental delay, also may have high rates of behavioral concerns and receive referrals to behavioral health providers. But they also have other challenges that distract them from being able to maintain good oral hygiene and self-care. So it's important that behavioral health providers on the team are monitoring those things. Some of our clients as behavioral health workers may already be under our care for things like eating disorders or substance abuse. These also clearly have an impact on oral health. Importantly, if these are identified early, these are exactly the types of presenting problems that provide an opportunity for early intervention and prevention, and that integrating our care across the team allows us to intervene early before these issues worsen. They help us to eliminate the health disparities, particularly for those patients who don't ordinarily see themselves having access to care, to dental care, like the ones that you pointed out earlier in the slide that access potentially medical care each year but don't access a dentist. We know that there are also, we've talked a lot about medical conditions and psychological conditions, but we also know that there's many social determinants of health, and that social issues, like unstable housing or homelessness, domestic violence, these may first be recognized by our behavioral health care teams. And our capacity to see the connection between these functional areas of the client's life and their presenting oral health issues or other conditions that have an impact on this really is important. I'd like to close by suggesting that it's important for us to recognize that even as early as 2000, when in the Surgeon General's report, there were quotes in there that noted that employed adults lose more than 164 million hours of work each year due to dental disease or dental visits. And they noted in that report that the social impact of oral disease in children is substantial. We know that more than 51 million school hours in that report noted were lost each year due to dental-related illness. And poor children suffer nearly 12 times more restricted activity days than higher income families. This doesn't even begin to account for the pain and suffering due to untreated disease that leads for problems in eating and speaking, attending to learning. On a national basis, most children with toothaches in the last 6 months saw a physician. 88.9% is, again, coming from the Surgeon General's report. They had a preventive medical visit in the last year. But it really speaks to that earlier slide of all the opportunities that we have in primary care to intervene and identify, specifically with children who have untreated dental decay and toothache.
This has really been an engaging conversation, and I think you and I can continue on for hours here, but there's just so much more we can explore. I'd like to take a moment and just pause and recap. And if we look at our objectives, for example, we have addressed considerations for the behavioral health provider to engage your clients in conversations about their oral health and enable them to identify when a client may have an oral health concern. We laid the groundwork for the need to establish and promote the interprofessional relationships that include the dental team alongside the primary care and behavioral health professionals. In the interest of time, and because we do want to engage the audience, the participants, we do have a number of resources that I'm not going to discuss with you, but I'm going to very quickly just show you what we have. This is a tool if you want to find where to get some dental care and services. This is the National Consensus Statement that we referred to earlier. There's a wonderful tool in there which you can use for your clients themselves. This is just a 4-page. One's for the primary care professional, one is for the dental professional, and there is one for clients. So feel free to use that. If you're interested in HRSA programs about oral health, we have our resources there. And then the HRSA report that Professor Glicken referred to, the development of the Interprofessional Education Oral Health Competencies for Primary Care. And then we've also included some HRSA-supported publications. And again, we'll make sure that you get a corrected slide so that you'll be able to see that more clearly. We also talked about a couple of times the core competencies, the Interprofessional Collaborative Practice that came out in 2011, the Surgeon General's report, both the published version in Public Health Reports, and then on the HRSA website is a more complete version that will also show you SAMHSA's activities in this area, and that's available on the HRSA website as well. Just some articles of interest on interprofessional education and reuniting the body. There's a wonderful webinar that one of our grantees, NOAA, the National Network for Oral Health Access, recently did on medical, dental, and behavioral integration. This is from a pilot project that we sponsored, and this is a webinar that is available for you to look at. Recently released from AHRQ, from the Agency of Healthcare Research and Quality, is a new guide. This is specific for behavioral health and primary care. This is a playbook, so I wanted to share that with you. There is wonderful, wonderful training available to you on cultural competency. This is the most recent one produced by the Office of Minority Health. This is using scenarios in the oral health environment, but also there is continuing education available for social workers on a previous version, so feel free to look at Think Cultural Health, Smiles for Life curriculum that we've discussed, and this is education on oral health specifically if you want to learn more, and then some other resources available to you. Some quick tips. We have 2 slides with quick tips and some resources and places you can go to find out more. And we'd like to say thank you, and I'd like to turn it over to Nick and see if we can open up the floor for questions.
Thanks, Dr. Joskow. This is, we did get quite a few questions from the audience, and so I thought I'd start out and ask this one to start. The question, to summarize it, really is asking, how do patients react when a behavioral health clinician really starts the discussion around oral health? And I think they're asking because it's just not something that, is a traditional question or dialogue between a behavioral health clinician and a patient or client. And then connected to that question, are there specific questions for the behavioral health clinician to ask or signs that the behavioral health clinician should be looking for to help address oral health?
Professor Glicken, do you want to start on the first half, and I can pick up the second half?
I think that's a great plan. I think the issue for clients and patients is whether you can help them or not. And by introducing the oral health history or the questions you want to ask, by suggesting that, as part of the healthcare team, you're concerned about any pain or any problem that the client may be having with their overall health. And so you'd like to spend a little bit of time talking with them about any kind of pain or problems they have in all parts of their body. And my experience has been, including in behavioral health myself, but with other health providers and professions, we haven't typically asked these questions, and we're much more concerned about asking the question than the clients are about receiving those questions. They're just happy, more often than not, that someone has taken the time to ask those questions and is concerned about the pain that they're experiencing or the bleeding or other effects from the condition of poor oral health and disease. So I think, again, that it may feel uncomfortable and unusual to us initially. However, as part of the integrated team, I think patients will increasingly come to understand that this is part of what we do.
Yeah, and I think that, how you go about doing it or what are the cues, I think I touched upon it a little bit earlier, and it is observing behavior. So if somebody is as Professor Glicken said, holding the side of their face, or somebody seems to have trouble speaking, or you notice a change. Let's say this is someone who you see on a regular basis. You notice a change. It gives you the opportunity to inquire, and a lot of it has to do with your approach and how you approach the question of oral health. It can be as general as, I know every time now we have a primary care appointment, everybody's always saying, rate your pain. Are you in pain? They don't ask where initially. It's just, are you in pain? Do you use tobacco? Do you drink alcohol? So you can actually use those as a icebreaker, shall we say, to get at some of these questions. The other thing, and I wanted to just point out, you can use the health history as a cue card because you're really interested as well in the quality of life of that client. Additionally, in order to get more comfortable with these things, I think you can, if you look at the Smiles for Life curriculum that we provided the tools there, or even on the HRSA website, our oral health page, we have an entire curriculum and program to how to address, specifically for children, oral health, but even Smiles for Life. I think once you start looking at some of those modules or look at the cultural competency training, that will get you more comfortable with understanding how to address these things in the dental environment or related to oral health. So I think as you start exposing yourself, you'll become more comfortable, and there are these educational resources and tools available to you to help.
Great. Thank you, Dr. Joskow and Professor Glicken. In the interest of time, we have about a minute left, so I'll go ahead and close. We'll actually try to answer some of those questions and send them out to our audience, so no worries. Okay, so that is all the time we have today. Once again, a recording and transcription of this webinar will be available on the CIHS website. Once you exit the webinar, you will be asked to complete a short survey. Please be sure to offer your feedback on today's webinar. Your input is important to us and informs the development of future CIHS or National Council webinars. I'd like to extend a huge thank you to our presenters, Dr. Joskow, Professor Glicken, for joining us on today's webinar. Thank you all for joining, and please stay tuned for more webinars in the near future. Have a great afternoon.